This is the diagram for the pathophysiology of ischemic heart disease. Two types of atherosclerotic plaques will lead to two clinical types of ischemic heart disease. The chronic stable angina in A, it's a demand-related ischemia. What do I mean by that? This plaque is a stable plaque. This plaque had a thick fibrous cap. This plaque will never rupture. It's always going to be there. It's obliterating the lumen. It's narrowing the lumen. It's decreasing the flow to the heart. So the ischemia is going to be demand-related. If you don't ask too much for blood, if you don't ask too much blood or too much oxygen, if you're just walking at ease, or you are resting, you're not asking for too much oxygen, you will not have any symptoms. But when you ask for more, when you demand more blood, when you're running, your heart is asking for more blood. Give me more blood, give me more oxygen. And now the coronary is obliterated by this atherosclerotic plaque. Can you have this more blood? And the heart will scream for oxygen. Give me oxygen. The scream coming from your chest is angina pectoris. Angina pectoris. It's the scream coming from your chest. And this angina, this chest pain is always exertional. Exertional, because when you are doing some exertion, when you're running, you're doing exercise, you're asking for more, but you cannot provide more. This type is demand-related ischemia with stable angina and stable atherosclerotic plaque. The other type, the serious one, the acute one, the one that will drive you to the ER, the one that will drive you even to the grave if we do not do something about it, is the supply-related ischemia. And in the supply-related ischemia, the pathophysiology is still an atherosclerotic plaque, but which type? The unstable one. The unstable one means what? It can rupture at any moment. It can rupture at any moment, even at rest. Even at rest, it might rupture. And when it ruptures, even at rest, immediately platelets will aggregate. Platelets will aggregate. All this is happening inside your coronary. Platelets will aggregate, and the platelet aggregation invites clot formation, and the blood clot will form. A thrombus will form. Look at these three diagrams. What's going to happen? The lumen is going to be narrowed very rapidly, very rapidly. So you can have any one of the acute coronary syndromes. There was no increased demand. All what happened was the blood supply decreased acutely and progressively because of this platelet aggregation clot formation thing. So this type is a supply-related ischemia. Supply-related ischemia, acute coronary syndromes, anything of unstable angina or non-STEMI or STEMI, as we're going to explain in a minute. Let's start by talking about the demand-related ischemia, chronic stable angina. The hallmark of chronic stable angina clinically is going to present as fixed pattern of exertional chest pain. If the chest pain is going to be cardiac, it should be exertional, related to exertion. Chest pain that comes on exertion and relieved by rest. And it always comes this way. It's a fixed pattern, fixed pattern. This is very chronic stable angina. Chronic stable angina. It's very predictable, chronic stable angina. And the pain does not change with respiration. It's not pleuritic. And the pain does not change with body position. It's not pericarditis. And the pain is just pain, not tenderness. It's not costochondritis. It's not inflammation. And the character of pain is usually dull pain, kind of compressing, squeezing, crushing. And usually the patient will put his hand on his chest. It's a crushing pain. And it's always substernal. It's always substernal. It's never to the left. It's never to the left side. It's always substernal, retrosternal. And the pain lasts anywhere between 15 to 30 minutes. So pain for few seconds is non-cardiac. Pain for few seconds is not cardiac. Pain for 4 days, chest pain for 4 days, definitely not cardiac. And the pain should occur on exertion, exertional pain, and is relieved by rest or sublingual nitrates. And usually it radiates to the jaw or left arm. I want to say that now we see a lot of atypical chest pains, atypical cardiac chest pains. It's not necessarily, so a lot of heart attacks present with epigastric pain. And it's not necessarily to find this radiation to the left side or to the jaw. Still, you can have chronic stable angina with atypical chest pain, but it's going to always be exertional. Chronic stable angina, pain that comes on exertion. Chronic stable angina, pain that comes on exertion, and it's always fixed pattern of pain. How to diagnose it? Stress test. Stress test. You have the history. And you do an EKG first. If the EKG does not establish the diagnosis, if the EKG does not show the manifestations of ischemia as ST segment depression is the EKG sign of ischemia, then I want to put the patient under stress and see how would the heart behave under stress. So how to put the heart under stress? I am going to give some chemical, some drug, dobutamine echo or dipyridamole adenosine thallium stress test. I'm going to accelerate the heart and see and assess the segmental wall motion abnormalities and see under echo how does the heart move. I can do stress EKG on a treadmill, but if the patient cannot exercise on the treadmill, like the patient who has COPD or amputation or weakness or previous stroke, for some reason the patient cannot exercise, then I'm going to give these medications, dipyridamole or adenosine thallium or dobutamine, and I'm going to do echo. So a 63-year-old woman with an abnormal stress test that shows an area of reversible ischemia. What is the next in management? What's next in management? Now, the patient had this stress test and showed part of her heart is not moving. So what to do next? The best next step is doing angiography. In order to locate the problem. Which vessel in the coronary has the problem? Which vessel is obstructed? So that when a cardiologist wants to put a stent, he will know where exactly to put the stent, at which vessel. And even you might need to do coronary bypass after that. Okay, very important to know the differential diagnosis of chest pain. Chest pain could be pleuritic, positional, pain with tenderness, or exertional. Exertional chest pain is the hallmark of ischemic heart disease. Ischemic heart disease, exertional chest pain. Ischemic heart disease, exertional chest pain. Pleuritic chest pain. Pleuritic pain coming from the pleura could be due to pulmonary embolism, pneumonia, pleuritis, pneumothorax. Okay, pleuritic pain that increases with deep breathing, pulmonary embolism, pneumonia, pleuritis, pneumothorax, pulmonary embolism, pneumonia, pleuritis, pneumothorax. Pleuritic chest pain, it increases, it worsens with deep breathing. Positional pain, pericarditis. It changes with position. Pain plus tenderness, costochondritis. It hurts at my chest, but it hurts more when I press, costochondritis. Exertional chest pain, ischemic heart disease. The most common cause of chest pain that is not cardiac is GERD, gastroesophageal reflux disease. What's the most common cause? Of retrosternal chest pain when it is not cardiac? Most probably is going to be esophagitis, secondary to GERD. And notice, this type of pain might be relieved by sublingual nitrates as well. So you have esophagitis, you have esophageal spasm, you take sublingual nitrate and it relieves it. This does not mean it is cardiac. The most common cause of chest pain that is not cardiac is gastroesophageal reflux disease. How to manage chronic ischemic heart disease? The whole thing is you want to keep a balance between the oxygen demand and oxygen supply, because your coronaries are obliterated, so they cannot increase their supply to the heart. So you want to decrease the cardiac demand of oxygen. How to do that? By decreasing the cardiac workload, decrease the preload, decrease the afterload, decrease cardiac contractility. And the medications we use for that, beta blockers, calcium channel blockers, or nitrates. And on the other hand, how can you dilate the coronaries a little bit? Maybe we can dilate them a little bit by using nitrates. So this is how we manage chronic ischemic heart disease. But first of all, how can we do prophylaxis for high-risk patients? Who are the high-risk patients? Diabetics, hypertensives. First of all, you need to give them statins to prevent the formation of the atherosclerotic plaque. Then you want to give them antiplatelets and anticoagulants, low-dose aspirin, antiplatelets, anticoagulants, even warfarin in very high-risk men. And ACE inhibitors also can have some prophylaxis benefit against ischemic heart disease. So this is as a prophylaxis. But how about treating ischemic heart disease? As I said, you reduce the cardiac demand by giving beta blockers, calcium channel blockers, or nitrates.